Thank you, everybody. Good morning from South Africa, and good day, and good afternoon, and good evening, wherever you are in the world. We are going to discuss a very important topic today about migration and displacement. And this has become, as we watch the daily news, I think has become a much more distressing part of our life and our thoughts around, how many people on our globe are actually being displaced. And this is not something that's getting better at the moment. It is clearly deteriorating in terms of the medical and human rights effects that this is having on humans. So this is a really important topic. And the way the gLocal JBI solution rooms are being set up is that actually it's a collaboration between different centers but in different parts of the world, which is really what we can see today. This is a webinar that aims to bring together academics, researchers, and practitioners working on a particular topic. And so this is a collaboration between the JBI Centre Ekurhuleni, where I'm from in South Africa, together with the University of Pretoria, but then also the JBI Evidence Synthesis and Implementation for Indigenous People in Kolkata, India, and the Medical Service Centre in India. Then there's Tampere University in Finland, and in collaboration with the WHO and the South African Public Health and Preventive Medicine Association. So many organizations that have come together to actually put this program together. And I really want to thank everybody who's on the program, who's gone into the trouble to actually prepare presentations for us. The good and the bad of having a virtual meeting is obviously we can bring people together that would otherwise not be able to have a discussion on this topic here today. But on the other hand, it sometimes does feel a bit distant, even if we've become now much more used to the virtual platforms. But let's make it interactive, use the chats and the Q&As, and let's not just be passive listeners to the presentations, but let's really have a discussion around the topic so that we move our thinking further. I mean, that's why we are actually having webinars like this, so that we are also maybe exposed to new ideas. And sometimes we are in our own echo chambers. We sort of discuss the same type of issues with people that have similar views to us and are from similar environments. And today is a big opportunity to get outside of our own echo chambers and really to listen to what other people are saying, and really to open our minds. And today is also a topic to open our hearts as well. I think that is it's an important part of clinical care, is not just to have an academic approach to the clinical issues that we're seeing. Obviously, evidence-based medicine is absolutely crucial. There's no doubt around that. But the point is still, we are health workers who also work with people with real life issues. So we bring our hearts to the world, to the job as well. And especially if we then meet patients who are really undergoing difficult life situations, just like the topic that we're discussing today in terms of migration and displacement. So that's the welcome from my side. We will, I think, is it right that we are going to have a video now from JBI Australia? And then I'm going to hand over to my co-chair so that we can then have the introduction of the different organizations that are part of today. Thank you very much.
Thank you. I think we can now play the introduction to JBI by Professor Zoe Jordan.
Hello everyone, I'm Professor Zoe Jordan and I'm the Executive Director of JBI, and I'm delighted to welcome you to the JBI gLocal Solution Room for 2025. Whether you're joining us here in person or tuning in from across the globe, we're glad to have you with us. This week, something remarkable is happening in cities, towns and digital spaces across the world. Researchers, clinicians, policymakers, and students from more than 60 countries are coming together, not in one location, but in many. And we're all here for one shared purpose: to advance evidence-based healthcare together. So what exactly is JBI gLocal? Well, it's a unique event series created by JBI, a global leader in evidence-based healthcare. Every year during gLocal Week, institutions and collaborators from around the world host events to share ideas, to showcase innovations, and to explore how evidence can be translated into better decisions, better practice, and ultimately better health outcomes. gLocal is more than just an event though, it's a movement. It's where the global and the local meet. That's why we call it gLocal, with a little g for global and a big local, because context matters. Now, why is context so important? Because, as the JBI model of evidence-based healthcare suggests, evidence doesn't exist in a vacuum. You can have the most rigorously synthesized evidence in the world, but unless it's understood and applied in the real world, in your hospital, in your community, in your health system, it won't change lives. gLocal reminds us that local voices and global knowledge are both essential. One informs the other. Together, they drive meaningful, sustainable improvements in health. This week, you might hear from colleagues across different disciplines. You might hear about innovations in implementation. You might learn about new evidence syntheses or explore real-world challenges and solutions. Each event is unique, but they all have one thing in common. From Australia to Austria, from Cameroon to Canada, from Switzerland to Sao Paulo, we're looking to find solutions to using evidence to create a healthier world. Across all of these gLocal events, JBI collaborating entities have carefully curated a program that reflects the spirit of gLocal. You'll enjoy sessions designed specifically with your context front of mind, and opportunities to connect, to question, and to collaborate. And just like every other event happening under the gLocal banner this week, you will be part of a global chorus of people who care deeply about improving healthcare through evidence-based action. We encourage you to share what you learn this week, not just in the room, but online, in your workplace and in your community. Use the hashtag JBI Solution Room to connect with others and to keep the conversation going. So once again, welcome. As I said at the start, you're not just attending a local event, you're participating in a global movement. Thank you for being here. Thank you for your curiosity, and thank you for your commitment to using evidence to make healthcare better for everyone, everywhere. Because that's at the heart of gLocal. It's your evidence, your context, and your impact. Thank you.
So that was a wonderful introduction from Professor Zoe Jordan. So let us move forward with the program and let Professor Jyoti introduce JBI Ekurhuleni. Ma'am, over to you.
Good morning, good afternoon, good evening. Thank you everyone for joining. Our Ekurhuleni Clinical Research Center, we are part of the JBI, as you heard. There are about 8 centers in African region, namely Ghana, Ethiopia, Kenya, Cameroon, and South Africa. And we are the second center established in South Africa in February 2023 under auspices of University of Pretoria and University of Adelaide, Australia, which is the main administrative center. And our center is the second JBI center in South Africa and number 8 in Africa. We hope that there will be more to be established. Our center actually run by very few over-enthusiasts, and our over-enthusiast volunteers and our valuable administrator, we are very few, and we are all volunteers. We come out, we have our own professional activities, and we come out of that, and in our evenings, in our holidays, and we work for our center to run the center and with its activities. Main focus of our center, although maternal, women and child health, but as you see today that we also conduct various other topics because JBI as a whole, that our members are coming from different disciplines. So we are actually able to host different types of symposium, although our main focus on maternal, child and women's health. And then we actually host symposium regularly, annually, and even quite a few times in the year. We conduct journal clubs from our center. We conduct scoping review and systematic reviews. And we also participate in various activities with the University of Adelaide JBI Center. And our future main plan is to start training on various JBI methodology, and which will be also, we'll be inviting anybody who wants to attend. And we hope to publish systematic and scoping reviews in future. And that's more or less nutshell summary for our center. And thank you for attending. Thank you.
Thank you very much. We will now move on to the introduction to the Medical Service Center. Is it Dr. Bera who will?
Hello. So the next is Professor Rutte. I think you have already asked for the next presentation. Actually, my connection was a bit, it was disturbing a bit in between. So we have the next presentation now of Center for Public Health Research and JBI Center for Evidence Synthesis and Implementation. Dr. Sasta Khatun will be presenting.
I'm representing Center for Public Health Research Month today for the event. And Month is a developmental organization established in the year 1960, and we work across 6 verticals of education, health, community media, livelihoods, climate action, and research, and covering eastern and northeastern parts of India with 116 trained and experienced staff. We have touched more than 1.5 lakhs annually, and the research wing of Month is known as the Center for Public Health Research, and we have been conducting primary research, systematic and scoping reviews, health economics with support from national and international academic and research institutions. And our team consists of development professionals from interdisciplinary backgrounds, earth sciences, economics, anthropology, public health, climate change and health environment, social work, child protection. The research team members include 4 PhDs, 7 postgraduates, and 4 field investigators. Our research areas are environmental health, health technology assessment, mental health, One Health, tobacco control, tribal health, and evidence synthesis. We are the 5th JBI center in India and the first one to be working on indigenous health. And this is dedicated to addressing the specific health needs of India's indigenous populations, a marginalized section of society with unique healthcare needs, cultures, customs, and social systems who suffer from a quadruple burden of diseases. And we focus on intersectionality, equity, evidence synthesis, and implementation. to generate the necessary evidence to bridge the healthcare gaps between indigenous and non-indigenous population. CPHR is also the National Center for Research on Tobacco Taxation, which is supported by Vital Strategies. And we're developing a tool for tobacco control enforcement in 5 states of India. We have also been selected as a RICE Regional Institute for Capacity Building and Training partner for the Saksham Praman project for East Zone to evaluate the targeted intervention projects on HIV/AIDS prevention. We are the doctoral training for Center for Manipal Academy of Higher Education. And these are some of the states that we cover in our activities. Thank you so much for having us here. Let's have a meaningful discussion. Thank you.
Thank you, Dr. Sajda. I think, Professor Rute, we can now call upon Dr. Gokhan Depo from Tempere University.
Hello. Can
Hello,
you
sir.
hear me?
Yes, sir, we can hear you.
Perfect. Can I have my can you have my presentation on screen, please?
Thank you. Can you give us a moment to present it?
Yes, of course. Yes. And I think then I can introduce myself at least. I am Gökhan Depo, and I serve as the coordinator for the WHO Collaborating Center at Tampere University. Today, I will introduce our collaborating center, our role, our work, as well as Tampere as a city and Tampere University, where I work at. I think I don't want to go any further without the presentation because I might steal some of my content from myself. So once the presentation is ready, I think I will just start presenting. Yes.
Yeah, that's starting to look good. If we can just get it into full screen, please. Yeah,
Yes,
that looks
perfect.
great. Thank you.
I think I just introduced myself. This is a collage for from our launch of our center. You can see some of the people there that was in the launch and our co-directors. Can we go to the next slide, please? Thank you. I think it's important to give a little bit of background information about Tampere because I'm quite sure that not everyone in our audience knows about the city. So Tampere is the second largest city in Finland, and we have a population about 250,000 people. It's one of the key cities in Finland. It plays a central role in economic development, also urban development. Tampere is often ranked as the most livable city in Finland, and it's a city that values education and innovation. Finland is a small country of about 6 million. We are a Nordic country up in the north, but all our photos are always sunny and full of sunshine. But in dark reality, in 6 months of the year, we're covered with snow. Can we go to the next slide, please? Of course, our university, Tampere University, is located within Tampere. We are the second largest university in Finland in terms of student enrollment. I think we have about 22,000 students as of this year and 4,000 staff members. And in that 22,000 students, it includes also 4,000 doctoral students. Our university is competitive. We have an admission rate of about 11%. We're also very active in global networks. And as a public institution, I think we're competitively ranked in global university rankings, appearing in the top 500 in almost every major ranking table. Next slide, please. And within Tampere University, we have our WHO Collaborating Center, for which I serve as the coordinator. Our collaborating center has a long name in its official designation. It is World Health Organization Collaborating Center on Health and All Policies and the Social Determinants of Health. But in short, we refer to ourselves as the Collaborating Center or WHO Collaborating Center at Tampere University. Our focus, as mentioned in our name, is on social determinants of health and health in all policies. And our center has three co-directors, Mary Koivisolo, Salla Atkins, and Lauri Kokkinen. Next slide, please. Our center was officially established in May 2023, and we held our official launch in September 2023. That day also marked our launch seminar, which we organized with colleagues from around the world, and I'm sure some of the people in the audience today were attending that seminar, and I met them face to face. Next slide, please. I just wanted to give you a very brief overview of the areas we're working on. First, we are working on strengthening the knowledge base on government strategies for advancing health equity. Second, we focus on strengthening the knowledge base on social protection and health equity. Third, we are working on monitoring the social determinants of health and health equity. And finally, we're working on increasing training and capacity building efforts on social determinants of health and health equity. Next slide, please. Unfortunately, we do not have enough time to go over all our activities. However, to provide a summary of what we have been busy with in 2025, I collated this slide. You can see that we have been active both in our online presence and in research, teaching, and global collaborations. Next slide, please. Finally, I wanted to talk about our ongoing talk series, through which we bring together a global audience and researchers to discuss topics that are central to the field of health and all policies and social determinants of health. We started last year, and we have monthly meetings, and it's online and it's open to everyone. And you can find more information about it on our website as well as the previous talks. Next slide, please. And I think it's the last one. Yes. You can find more about us and get in touch with us through our social media channels or website. And this unfortunately concludes my presentation. This was a very brief one, but the larger, more detailed presentation, I think, will be submitted either on the website or somewhere here on Zoom that I was told. There are more information there regarding our work and how we can collaborate for those who are interested. Thank you very much for listening to me, and I think I can now stop the presentation, or you can stop the presentation. Thank you.
Thank you, Dr. Depo, for the wonderful presentation. It was very nice to hear from you. And I think we can move forward to our next sessions. Professor Ute, if you would like to add on anything.
No, thank you very much. If all centers have been able to introduce themselves, then that's perfect. Then we will hand over to our next session through the session chairs of session 2, and that concludes our first session. Thank you very much. So we will move into session 2 now. Thank you.
Good day from Tampere. Can you hear me?
Yes.
Okay. Hello, I'm Mikko Perkiö. I have honor to be the session chair in the session number 2, and we are going to continue from the first session, and we have 3 15 minutes presentation. First, we will have Dr. Nicole Valentine from WHO headquarters. Then I will give a presentation on migration and displacement in Finland, and as a third presentation, we will hear about migration in India by Mrs. Suraya Roy from JBI India. So that's and then we will have 15 minutes for questions and answers after these presentations. So I have an honor to welcome Dr. Nicole Valentine from WHO headquarters. The floor is yours.
Thank you. We will be playing the video from Dr. Nicole.
Okay, lovely. Thank you.
I'm going to tell you a bit about the special initiative WHO launched with partners in 2021 and share some learnings we think are important for considering when addressing the social determinants of health equity for migrant populations. We call the initiative SEMASHI. That's its acronym. WHO's work in social determinants draws heavily on that by the Commission on Social Determinants of Health, whose report in 2008 highlighted the need to tackle structural factors on which the living conditions so important for health depend, whether globally, nationally, or locally. Drawing on this vision, the goal of SEMASHI is by 2028 to ensure that health equity is integrated into social, economic and development policies to improve the social determinants of health for at least 20 million people in 8 countries. The vision is one where health equity is a global societal value, ensuring that all social groups enjoy healthy living and working conditions. This is done through exercising a mission around strengthening capacities for intersectoral strategies and practices to address the social determinants of health equity successfully and to support knowledge sharing, evaluation and contextualization of these practices. SEMASHI has involved work in 3 WHO regions thus far and across 8 country pathfinders you see on this slide. It's based around 4 work streams that come together to promote on-the-ground delivery in Pathfinder country action. A key work stream obviously is strengthening the regional and country support, but it's complemented by 3 global work streams that are equally important to create the architecture socially, economically, and the political will, as well as the global evidence for advancing action. And these include advocacy, training and mainstreaming, and obviously advancing the evidence base on which the World's Report on Social Determinants of Health Equity was a key product. The causation framework initially set up by the initiative is shown on this slide, which draws on the Americas Commission, which was concluded in 2019, but it's based on the original Global Commission on Social Determinants, showing the non-biomedical factors, the social factors, which are really influencing the patterns of health equity seen in different populations, with a decision at the time, which was the discussions were 2020 around about, to focus on informal settlements, work precarious employment, migratory processes, and processes of social inclusion through social policy. So that was the discussion that we set at the time and the interest of the countries and regions involved. At the time, the PAHO region had done an analysis looking at how does the migratory process actually generate health inequities. And some of the thinking is shown on this slide, where one looks at both the causes of migration, the migration process, but then also the context in the country of arrival, and then how the migration policies impact then that context in the country of arrival, considering these other factors related to country of origin and the actual process of migration. So in considering the social determinants of health, it's more complicated again, because it's not only looking at the access of health care, migrants to health care, but the broader rights that migrants enjoy in their arrival countries. Just coming back to complete the picture on the special initiative, it is a partnership with the Swiss Agency for Development and Cooperation, a clinical department that works on the interface between clinical work and then social policy, based out of Lausanne. and then the Institute of Health Equity based at University College London, led by Michael Marmot, who obviously probably you've all heard of, who has led the Global Commission for WHO, regional commissions, and also works very actively in his own country to promote policy change. Up to now, we've had at least 20 local areas in 6 countries demonstrating models on the ground. And we've also worked on, as a group, some joint activities and products, which are also ready for sharing the experiences more broadly with other audiences. We don't have at this stage lots of very specific products on migration and health, but I'm going to share with you some of the work that's in process. Taking a step back, one important thing to think about when thinking about the special initiative is the guidance that we gave to country partners from the outset, and that was that to make work at the local level is quite central. And what relevance this has to migration and policies for migration is that the theory is that the test is really at the local level. So how is the policy reflecting on the actions of local actors, whether it's local government or civil society that they work with, or local health services? And really the policy on paper can only really be seen in the way that it's going to either generate benefits or harms at the local level. Another important area of governance instruction was around the fact that we're addressing the structural determinants. So it's really looking at the rights that populations have, opportunities that they have, the budget allocations according to public policies. Second point is the intersectorality of the approaches needed to resolve and to improve the determinants of health. Thirdly is the importance of the community engagement process, which WHO advocates for in a lot of areas. But again, community engagement looking broader than health services, perhaps also the barriers to health services, but then more broadly the barriers to good health. And then finally, having the evidence-based interventions presented and having that as always part of the conversation in the networks, and sharing then and documenting and learning from other actors. Coming back to some of the joint products in 2023, after working on this from 2021, actually, we did the SEMASHI group documented a literature review of hospitalization, morbidity and mortality rates of COVID and identified groups most affected, in which there was evidence that migrants were more highly affected with worse rates in all of those 3 categories. And then the SEMASHI also stressed the importance of migration as a structural process in input in the development of the World Report, which was overseen by obviously a global group of experts and policymakers. But some of this experience of SEMASHI would say influenced strongly the report. There is one key recommendation area. There are four big areas, and one of those 4 is about addressing the determinants and impacts of migration, and also links this to discrimination, conflict and emergencies. Another area of recommendation relates to increasing the universality of public services, specifically around social protection systems, and the evidence that has been assembled also looks at the interconnection between social and healthcare systems, and this is particularly important in the case of migration. One of the importance of the social protection and better linkages between social and health services has been stressed through joint webinars and outreach meetings that SEMASHI's been involved in with the ILO. And among the special issues or specific issues discussed has been the reduction of the incidence of TB. Here are a list of resources important for connecting social and health protection and care systems. This is one important intersectoral area for policy. Policies that address migration and health relationships need to consider these different pathways of impact. And from now on, I'm going to turn to some of the specific, more detailed work that the Americas region within SAMASHI has been working on. And drawing on that earlier slide, which showed the origins, the migratory process, and then the country of arrival and the migration policies and how they have to deal with the social determinants of health. Here we look at how the migration health relationship is impacted through policies that impact self-selection to leave the country of origin, policies related to health in migrant settlements, the actual migrant health outcomes themselves, which then have further implications for social determinants of health, the health system outcomes when they're dealing with migrants and refugees. Migration can also be the process of migration, a vector for disease transmission. And then there are also issues related to the health of migrants' families if they're left behind, and the impact this has also on the health of migrants. Their ability to work, to send money home for the healthcare costs of families left behind. So as part of the work, they've identified different strategic lines of action. They're covering three main policy areas: migration policy and regular conditions of stay, the health policies, are they migration sensitive, and then strategies specifically for the inclusion of migrants related to labor, education, social protection, broader social policies. So really, last slide related to the PAHO work deals with monitoring. They've, in addition to general intersectoral governance, collaborative arrangements, monitoring is one of the cross-cutting issues on social determinants of health that has some specificity in the case of migration. PAHO has come up with a particular list of data that should be collected, as shown on this slide. So looking at some of making visible the structural elements of a migration policy by looking at working conditions, housing conditions, social inclusion experiences, and then also collecting data related to the particular individual country of origin, how long they've been in the country, and specific endemic diseases, trauma, occupational health, and access to health services questions. So that, in summary, is the work that PAHO has been busy with. And now for my last slide, I'd just like to conclude, drawing things together. Firstly, there are general lessons on joining up local and national levels from SAMASHI, with local effectiveness as being a standard for testing the effectiveness of migration policy and promoting health. Second point is how we have to consider the broader processes of migration and how the broader policies across sector impact the health of migrant populations, not just health services in isolation. So some of the conceptual work showing the interconnection between the experiences in health services, but also the impacts of access to opportunities in society more broadly and rights is very important. And then thirdly, having to collect specific data to understand and monitor the impact of policies on migration and health is an important lesson. So thank you very much, and I wish you a successful conference.
Thank you for this eyes-opening video presentation from WHO headquarters to Dr. Nicole Valentine. And then we move on to the country context. First, I present myself, Finland as a context of migration and displacement, and then we move on to India. Just a second. Is it visible? Okay, lovely. Okay, thanks there. So I'm Mikko Perki, I'm senior lecturer in Tampere University. My research has been cross-sectional, transdisciplinary research between health and social policies. And to start the broader context currently in the Northern Europe, international politics influence to the displacement and migration politics more than during a few decades earlier, and that's why we start with situation in Ukraine, so that influences a lot to European context with displacement and migration. As the I would put it, Russian war in Ukraine, due to that there is a largest forced displacement crisis in Europe since the World War II. Roughly 10 million Ukrainians are displaced. Either they needed to leave their country or they are internally displaced. And so it means 1 out of 4 Ukrainians are displaced, as the country's total population is between 30 and 40 million up to ways that we count. Finland takes, as we are a country of less than 6 million people, so we take our share to support displaced Ukrainians, and currently there are roughly 50,000 Ukrainians getting temporary protection and staying in Finland. And those displaced Ukrainians in Finland, definitely as the economic situation is not a perfect at the moment, there are employment challenges and mental health challenges for various reasons, and for the trauma and for the social relations, natural reasons. Another context of Finland, as said, that we are a population less than 6 million, roughly 10% are foreign born, and some big numbers that Finland's immigration service tackles around 200,000 applications in a year. Residence applications, and which mostly turn to be positive issues in large share. And as we see that our migration department issued 120,000 residence permit decisions and only 4,000 asylum decisions in a year. Definitely there are European asylum. There is some policy tightening across Europe, and there was more asylum also from Russia, as some people were leaving Russia for the war. So there was more asylum application in a couple of years earlier, and now there is a drop in number of those asylum applications in these. And then some streamlining or that sort of with border procedures have been there within the European Union and within Nordic countries. And so that sort of tightening in the policies are visible, as well as there was a major reform transferring integration responsibilities from state to municipalities. So earlier it was state and municipalities playing together, but now municipalities have a bigger role. And further on these stricter border controls was linked to the Russian war in Ukraine, that as there was a tension from Russia towards neighboring countries in the West, using migration or that sort of instrumentalized migration as a tool, which then led for Finland, as Finland has more than 1,000 kilometers border with Russia, so tightening the border controls, and also applying that sort of policy of reject or push back asylum seekers with that sort of rapid decisions. So that's part of the policy. But then more that sort of steadier labor and student migration trends that roughly 15,000 applications, that sort of first work-based residence permits are there annually, and largest that sort of work-based residence permits groups are from Asia, Thailand, the Philippines, India, China, and Vietnam, and that sort of high-skilled end of those Asian applicants are from India. And student residence permits are annually roughly on the same level than work residence permits, about 15,000 in a year. And this kind of political and societal shift that has been taking place in Finland is also part of the larger European Union trend, and linked to that sort of Russian war in Ukraine and related instrumentalized migration. But on the more peaceful side, the EU is promoting legal pathways based on talent, skills, and European labor, addressing European labor shortages. So there is that sort of work-related migration as well, and all types of integration challenges are there to be addressed at European, as well at the European level, national level, and also on the municipality or local level. And Ukrainians are the big challenge for Europe to integrate the displaced Ukrainians. Moving to migrant health concerns in Finland, there has been a very robust migrant health service conducted by the National Research Institute for Health and Welfare. So we have quite a good picture on general migrant health challenges, as well as that sort of disaggregated outcomes in different migrant groups. But having that sort of broader view first, definitely there are mental health challenges across the large part of the migrant groups, of course, depending on what are the grounds of migration. And as well, chronic diseases are there, but those are more that sort of related to the groups that if probably we can identify cardiovascular challenges in Russian migrants, and then probably diabetes are there from more typical for certain other for example, people coming from Middle East and so forth. So that sort of chronic disease vary a bit in relation to the country or region of origin, as does the infectious disease. So tracking those is one issue, but that's probably a minor issue. Then definitely there are service barriers, as Finland has official language Finnish and Swedish, so language build some service barriers in accessing to health services. And further on, reproductive health concerns are there also, related to cultural or regional background of the migrations. And social health factors, integration to job market, labor market is a major determinant for also general health. So so in the discussion we can distinguish different regional or that sort of country-based profiles. So I can debate on those profiles or disaggregated health profiles of the migrant groups possibly in the discussion. So these are the key reflections on Finland's displacement and migrant situation currently. Thank you very much, and discussions is about to follow. Thank you, and we move on then to the next speaker. And as said, discussion will be there in the end of the session. And next speaker is Mrs. Suraya Roy from JBI India. You are warmly welcome.
Hello. Am I audible to you?
Yeah, we can see that, but it's not full screen yet.
Okay. Right now, is it okay?
It's okay now. And,
okay.
And I will confirm once the slides are moving.
Okay.
Okay, it's moving nicely. Thank you.
Okay. Firstly, I'd like to sincerely thank everyone for providing me with the opportunity to present my study in the webinar. So first, I want to talk about the classification of migration, that migration can be broadly classified as permanent and temporary migration. Apart from huge impact of globalization and significant increase in communication and transportation in the developing world over the past few decades, the most migration occur internally, according to global estimates such as Human Development Report. Evidently, most of the internal migration migrants are labor migrants, and significant proportion of them migrate on a temporary basis. So in our study right now, we are focusing on the internal temporary migration. So temporary, 90 in India, 92% of Indian workforce is in the unorganized sector, and it had of seasonal migrants. Okay, and with the however, there's a lack of reliable data on temporary migration. The only source of data is National Sample Survey data, and it's published in 2007 and 2008. Apart from that, we have to rely on the micro level studies. So the macro level studies indicate that the rate of temporary labor migration in India is 7 times higher than the permanent labor migration. There are significant social differences between the temporary and permanent migration. Temporary labor migration is mainly with a strong pattern of rural to urban migration. Micro level studies indicates that temporary migrants are more likely to come from a poor, disadvantaged caste group with low level of education. And temporary labor migration in India largely serve as a surviving strategy, unlike permanent migration, which often reflect the different socioeconomic motives. The likelihood of temporary migration decreases with the improvement in the economic status, education, and social position, especially in the rural areas. Uh, uh, Macro level studies indicate that temporary labor migration is primarily concentrated in North India, especially in low income agrarian states such as Bihar and Uttar Pradesh. Apart from that Odisha is another high out migrating states. Some high income states like Gujarat also experience a high temporary outmigration among poor and tribal communities. Some studies also indicates that the main destination for migrants are towards the developed states such as Maharashtra, Delhi, and Kerala. However, if we focus on the West Bengal, the migration history of West Bengal is quite different from other states, uh, with high outmigration rates such as Uttar Pradesh, Bihar, and Odisha. West Bengal transformed from position of net about the 1980s to one of net sender of migrants. The inflow of migrants to West Bengal from different parts of India can be tracked back to the beginning of the 19th century, when the process of urbanization began in the east part of India, on Kolkata city, due to abundance of infrastructure such as port, an internal river transport system, and well-developed communication and transportation system. Apart from that, industrial growth that could be seen in Kolkata surrounding areas. The industrial sector of West Bengal was the destination of the workers from different parts of India, and such as Bihar, Uttar Pradesh, Odisha, and also Chennai. Furthermore, a significant number of seasonal migrant workers were employed in the agriculture industry during harvest season. Migrant, the seasonal migrants made a lot trip to West Bengal's rice bowl in the Burdwan district also. In terms of per capita NSDP, West Bengal held the second position in 1960. However, it fell to 13th position in 1990 and 91, and the 26th position in 2015-16, and lastly 22nd position in 2019-20, which is less than the average per capita national state domestic product for all India. Furthermore, according to some studies, such as Chattopadhyay, the state lost its status as the hub of commercial industry from 1960 onwards. Post 1960, the state has not seen in the same level of development in the labor-intensive industrial sector as it has in Maharashtra and Gujarat. According to 2000, besides that, according to 2011, the 2011 census data, the proportion of working age population in West Bengal is very high. Further, the state enjoys a lower dependency ratio compared to all India. This implies that the state enjoys a demographic dividend. Along with this, rural non-farm activities Along with this, rural non-farm activity patterns are changing structurally also. And the non-farm sector is expanding across the states. However, it is found to be inadequate to provide jobs to the substantial portion of the working population that it's semi-skilled and unskilled worker. With this demographic dividend, in contrast to low level of industrial growth and insufficient employment opportunities, in the non-farm sector, the working age population's immediate choice is to relocate to other areas, other districts with a high employment rate. Evidence reveals that West Bengal is not only less appealing to migrants from other states like before, but also that the state struggles to provide adequate jobs to its own working age residents. As a result, both in the rural and urban sector, out-migration rate have risen. And the table shows that the internal migration scenario in West Bengal compared to India, and it is observed that rural to urban migration is quite high. So in our study, now I am focusing on two districts of West Bengal. It's as a case study, and my focus is to understand the nature and pattern of the migration, and to understand the occupational transition of the migrant workers and the health condition of the migrant workers, and at last the association between temporary migration and its socioeconomic determinants. So here we have selected two districts, one from southern parts of West Bengal, another is from northern parts of West Bengal. And we from each district, we have selected two blocks. One is comparatively backward, another is comparatively advanced. And from each blocks, we have selected for two Gram Panchayat, and from each Gram Panchayat, we have selected two villages. And to understand the fact that influences the decision of the migration of the individual or of the households, we have estimated logit regression. And these are the land holding, caste, gender, religion, and years of education, household size, age, sex ratio, dependency ratio, and marginal per capita consumer expenditure, date, marital status, and religion are the dependent variable. Now, if we look into the workforce participation rate with migration offers, we have observed that in South Chobbi Pargana, into religion, the workforce participation is high. At the same time, migration also high. And in Coach Bihar district, we have seen the opposite thing. The workforce participation rate is same for both religion, but the ratio of migration is high among the Muslims. And if we consider the social groups, we have observed that the workforce participation rate is among the caste and tribes, and rate is also back caste and tribes. But this picture is not seen in another district, that is backward district, Coach Bihar district. We have observed the workforce participation rate high in the scheduled caste and scheduled tribes. However, the rate of migration is high among or us. If we focus on the land size or the land holding, we will observe that the workforce participation rate is high in the advanced district. In individual holds 0 to 1 hectare land in Bigha land, workforce participation rate is high. However, the migration rate is high among the landless households. If we look into the backward district, we have observed that workforce participation rate is high among the individual who have the 1 to 3 bighas land holding, but the migration rate is high among the less than 1 bighas of land holding households. If we look into the marginal per capita consumer expenditure, we have observed that poor individuals have high force participation at the same time, high migration rate in both the districts. If we look into the average years of family education, we have observed that 0 years education households have high workforce participation. However, 1 to 5 years of family education has a high migration rate in advanced districts such as South Chobbish Pargona. But in backward district, we have observed the similar high workforce participation rate in the 0 years of education, family education households, at the same time, high migration rate. Now, if we look into the process of migration, we have observed that first we have observed that the percentage share of forms of outmigration from the study district. We have observed two distinct type of migrant household. One is single member migrant household, another is multiple member migrant household. In South Chobbish Pargona or advanced district, we have observed a larger proportion of working individual within a family is associated with a higher prevalence of multiple member migration. However, in Coach Bihar district, we have observed that households belong to socially backward communities, that is, scheduled caste, scheduled tribe, and low land holdings have multiple member of migrant families. Regarding the share of duration of stay at destination of out migrant, we have observed that in the advanced district, the phenomena of out migration commonly persist for a duration of 9 to 11 months, while in Coach Bihar, it typically ranges from 6 to 9 months. And the more interesting part of the seasonal migration is the recruitment process. And we have observed that in both districts, more than 50% migrants migrated and secured their job through contractor, locally known as Thikadar, Shordar, or neighborhood villagers or neighborhood village or supervisors. Apart from that, 38% in advanced district and 27% in backward district recruited through their family members, experienced migrants, family members, or villagers or friends. And in South Chobbish Pargona district, 26%, and in Coach Bihar district, that is backward district, 30% migrants migrated individually without depending on advance or without any connection. Now, if we look into the destination of those migrants, we have observed that in both districts, maximum number of migrants prefer to migrate towards urban areas of other states. If we look into the geographical location of the South Chobbish Pargona and the Coach Bihar district, we will see that Coach Bihar district is in the border of Bhutan and Nepal. However, South Chobbish Pargona is in the southern parts of the West Bengal, and it's near to the metropolitan city Kolkata. So it is observed that in South Chobbish Pargona or the advanced district, after the urban areas of another state, the destination of the migrants is in the urban center of the West Bengal. However, in Coach Bihar, the destination is the neighboring countries such as Bhutan, Nepal. And the major destination states from the South Chobbish Pargona districts are Kerala, Maharashtra, Karnataka. And from Coach Bihar is the Karnataka, Rajasthan, Arunachal Pradesh, Nepal, and Bhutan. Now we look into the occupational transition. Here we have observed that in South Chobbish Pargona or advanced district, the highest rate of out-migration are observed among the persons who were previously involved in agricultural and non-agricultural wage employment in their places of origin. And the main wage rate, and the mean wage rate at the destination is rupees 300 to 350 for agricultural laborer and rupees 300 to 400 for non-agricultural laborer. However, if we look into the backward district or Coach Bihar district, the migration rate is higher among the unemployed. And after migration, there converges into the non-agricultural wage workers. And here we have, in this table, we have observed that in the study, the main destination of the migrant worker is in the construction sector, bricklaying sector, and the textile sector. In the construction industry, located in Kerala, Delhi, or Bengaluru, or Bhutan, provides employment to more than 50% of the migrant population. In the construction industry, when migrants first moved, most of them migrated as unskilled laborers, such as helper. In Kerala, the wage rate of the unskilled worker was rupees 350 to 400, and for semi-skilled worker, it was 500 to 600. In Bengaluru, it was for unskilled worker, it was 300 to 400, and semi-skilled worker, it was 400 to 450. And in the textile industry in Kolkata, Bombay, Hyderabad, Delhi, Gujarat, including garment units and embroidery, most of them are semi-skilled and are paid up at a piece rate. The average earning per day for the semi-skilled worker is rupees 600 to 750 for skilled worker, and 900 to 1050 for skilled worker. And the working hour of the migrants were 12 hours in a day. And those who worked in bricklaying sector, 15.98% of the migrant works among the works in the bricklaying sector in Bihar, Nepal, and they migrated with their families, including children. This kinds of migration appears to be a domain of the poorest migration. So as a result of that, the health condition of the migrant workers are influenced by several factors, such as including the nature of work at destination, workplace condition, etc. For example, in construction sectors, migrant workers suffer from communicable diseases such as tuberculosis, skin disorder, and non-communicable diseases like musculoskeletal problem, eye disease, so on and so forth. And here is the reason behind these health issues. One is prolonged working hour, another is occupational hazard and lack of adequate nutrient and sleep, and poor living condition and exposure to infectious diseases. Apart from that, female migrant worker face, though in our study, the share of female migrant is too low. They only migrated to bricklaying sector. Female migrant worker faces even high health risk, exacerbated by lack of healthcare access and reproductive health challenges. As a result of that, there is a vicious circle of migration, we can say that. As a result of their working condition and the lifestyle, they have some respiratory diseases and some tuberculosis and reproductive health issues. To cure that, they spend a lump sum amount of money, irrespective of their social securities or any kind of insurance policy. So there is an increase in out-of-pocket expenditure. As a result of there's a decline in the amount of remittances, and at their origin or at their home, they spend the money, the remittances, only for their survive. So further, they have to migrate in the next season also. So here is the vicious circle of migration, or vicious circle of migration related health issues. So at the last, we have estimated the logit regression to understand that individuals migrate. So in both the district, we have observed that small landholdings, high dependency ratio and poor economic condition of the household play a significant role in determining whether to migrate of an individual. If we look into the individual factors, comparatively less educated males and males are more likely to migrate. And if we compare this two districts from backward district, that is Coach Bihar, the migration rate is high and more significant. And if we look into, if we look into the estimations separately for the two districts, it reveals that the main driving forces behind migration in the advanced district are the poor economic condition of the households and the high dependency ratio. On the other hand, migration is encouraged in the backward district by lower marginal landholding, a lower sex ratio, and a higher dependency ratio, and the poor economic condition of the household. It also shows that those with less education tends to migrate more. At the end, the conclusion, we can say that in both the district, the labor migration is deeply influenced by gender, age, education, and economic vulnerability. And it is male-driven, with younger, less educated individuals from economically weaker households are most likely to migrate. And here, social network plays an important role to provide employment, to facilitate other things related to migration. And apart from that, the health challenges faced by the migrant worker arising the long working hour, hazardous job condition, poor nutrition, inadequate rest, and unhygienic living environment. And it deepened their economic insecurities. High out-of-pocket health expenditure restrict their ability to save or build asset, often trapping them to repeated migration. It is also observed that the persistence of regional inequality and the absence of adequate social protection system underline the urgent need for the targeted policies that addresses both the livelihood and health vulnerabilities of migrant workers. Comprehensive interventions for local employment, portable social security, decent working conditions, and accessible healthcare are essential to provide the well-being and stability of the highly mobile labor forces. Thank you.
Lovely. Thank you, Suraya Roy, of sharing these findings from the very robust regression study and introducing that Indian landscape of largely internal migration and related challenges. Very good. And now it's time for questions from the audience. So just raise your hand and ask questions. We can spend 5 to 10 minutes up to the number of questions that are available. And then we will have roughly 10 minutes for tea break. Thank you. So who wants to ask? Probably I asked, as I have studied with my student and colleagues in Manipal University, construction workers and their challenges with healthcare access. So and it linked to the results that it was just shared, that out-of-pocket payment and new finding some distrust to public services and extensive use of private services if the informal construction workers could afford. So I wonder how do you see the challenges of internal migrants and informal workers in India with their use of, do they have access, what is their access to health services? I would like to ask from Mrs. Suraya Roy.
Hello. Please repeat your question once.
Sorry?
Please repeat once again. Actually, I can understand your question.
Yeah, challenges with internal migrants and largely informal sector workers. How do you see their what is their access to health services?
Sorry. In the individual states in India, they have their own healthcare services like health card and all. But there is a problem regarding using this card to another states, using the healthcare facilities to another state, because they have to understand the languages in the destination. They have to understand the procedures. So there's some lags, communications lags in the migrants, or there is some facilities from government side also. There's a lack of government facilities also for the migrant workers.
Yes. Do they have the ID card or that sort of card giving access? Is it related?
Yeah, right now they are. Yeah,
to their own home state or to the state that they are working in?
Yeah. So right now migrants are having e-shram cards, that is government initiative card for the migrant workers as well as for the informal workers. I hope that through these cards they will access the healthcare facility in the government hospitals as well.
Okay, so there is a government initiative or improving the rights. Yeah, good. Questions from the floor, please. If no questions, then I thank very much for the speakers of this session, and we will have about 10 minutes tea break, and we will start next session in quarter past 3 in Indian time and 11:45 South African time. Yes, please. Okay. One question, please. Who would like to ask? If somebody is asking, they are muted. He or she is muted.
Sorry, Chair, there's a question in the chat box.
Okay, lovely. Okay, sorry, I missed that. Just a second.
Hello. Actually, we have identified the districts on the basis of their earning, total earning of the district. We have identified them as we had marked them as advanced and backward district. we have only considered the economic indicators, such as earnings.
Okay. And then there is a question on whether Wikipedia is a reliable source on data on Ukrainian refugee. Okay, that's I can just. It's a challenging question on the situation of war. Probably it's better to rely on also other sources than Wikipedia's. Then there is an interest to influence. There might be that sort of extensive interest to influence Wikipedia. That's sort of widely used information channels or information producers. So probably it's better to rely on at least two sources of data. So at least one or two more on issues on Ukrainian refugee. Thanks for good questions, but I think that sort of extensive war really cast doubts or challenges for the data quality and also to Wikipedia. Thank you. And one more question or answer. Okay, nice answer by Suraya on the study. That's nice. Is there any more questions? The floor is yours. Just be vocal and ask your questions. We can have one more question before tea break, if anybody wants to ask. Probably not. So no matter, we have covered quite a diverse contexts from India, Finland, and global in this session, and hopefully it contributes to your needs, tackling displacement and migration challenges globally. Thank you, and we'll continue after about 8 minutes. 8 minutes tea break. Many thanks for your attendance, and have a wonderful workshop onwards. Thank you very much.
Okay, so let's welcome Dr. Subrata Mukherjee, who is currently a professor in Dr. Babasaheb Ambedkar Chair in Political Economy at the Mumbai School of Economics and Public Policy. He is currently on leave from the Institute of Development Studies, Kolkata. He holds an MPhil in Applied Economics and a PhD in Economics from the Center of Development Studies, JNU. He received the Canada Hope Fellowship from the Canadian Institute of Health Research. He was a postdoctoral fellow at the International Health Unit of the University of Montreal from 2008 to 2010. He is one of the founding members of the Indian Health Economics and Policy Association and served as its joint secretary and secretary for many years. His areas of research interest include labor and migration, health inequality, elderly population, informational asymmetry in healthcare, health financing, the economic burden of chronic illness, and the economics of education. His teaching interests include health economics, quantitative methods, field survey techniques, and machine learning models. Welcome, sir. Next, we have Dr. Nontembiso Magida, a PhD and member Ekurhuleni Clinical Research Center, South Africa. Dr. Magida is a lecturer in physiotherapy at the University of Pretoria. She completed her PhD in physiotherapy at the University of Witwatersrand. Dr. Magida is very keen with community engagement and coordinating interprofessional healthcare leadership for School of Healthcare Science. Dr. Magida's research niche is interprofessional collaboration and public health. She is also a reviewer of PLOS ONE journals. Welcome, ma'am. So I'll hand over the session to both the chairs. Let's proceed with it. Thank you.
Okay, I hope am I audible?
Yes, sir, it's clear.
Okay, so I hope my co-chair is here. So we have two presentations for this session.
The co-chair, Dr. Makita, actually sent an apology sometimes before that she won't be able to join because she's attending a conference elsewhere. So unfortunately, I think Dr. Mukherjee has to take it alone.
Okay. Yeah, it's perfect. Okay.
Thank you.
Thank you for letting me know. So we have two presentations for this session. And how much time do you have, by the way? We have 45 minutes. Okay. So without wasting any more time, let's start the presentation. So may I invite the first presenter, Dr. Miriam Orkut. The paper is South African National Research Agenda on Health, Migration and Displacement. Yeah, over to you, Dr. Miriam. Dr. Miriam, are you there? Okay, it looks like we are not connected to Dr. Miriam. So I see Dr. Sajda Khatun is here. So may I now request Dr. Sajda Khatun to start her presentation? The title of the yes. So the title of your paper is Living on the Edge: Climate Change, Migration Decisions, and Societal Impacts in West Bengal. Yeah. Yes, please.
My colleague Dr. Surya Rao has already given an overview on the trends of migration in India, and I'm going to present a little case study that we've done here in the state of West Bengal, district Purulia. Climate change has significantly altered the hydrological cycle, leading to an increase in the frequency and intensity of droughts globally, which in turn has become a critical driver of human migration. Drought-induced livelihood losses, particularly in rain-fed agricultural regions, often force populations to migrate in search of alternative employment and better living conditions. In India, climate-induced drought has had pronounced effects in semi-arid and drought-prone regions such as the Bundelkhand, Marathwada, and Purulia, exacerbating rural distress and seasonal or permanent migration. Hence, the spatial dimensions and socio-economic impacts of such migration remain under-researched, necessitating integrated approaches using GIS and climate modeling to inform targeted adaptation policies. Droughts in India are caused by three main features like altered weather patterns, which disrupt the traditional climate patterns, resulting in unpredictable rainfall, prolonged dry spells, and overall reduction in water availability. Second is by rising global temperatures like intense heat waves, leading to higher evaporation rates from soil and water bodies, which contributes to increased drought severity, affecting agriculture and water resources. And there is variability in monsoon rains, threatening agricultural sector overall and exacerbating the drought conditions. Droughts have multifaceted effects. Firstly, depleting water resources, both in terms of groundwater and surface water reserves, and which forces communities to face increased competition for water and prompting migration towards areas with better resources. Reduced crop yields lead to food shortages and threaten the food security of millions as agricultural production declines. Farmers face financial hardships due to reduced incomes from failed crops, leading to increased debt and poverty, and the cycle continues. Health also is affected by droughts because of severe water scarcity. The situation elevates health risks like waterborne diseases and inadequate hygiene practices. So, the objective of this small study was to understand the decision making process associated with migration and health impacts on households' livelihoods. Our study area is Purulia, a district in western part of West Bengal, which is characterized by significant precipitation and temperature fluctuation, and which has significantly impacted the agricultural productivity of the region. Recent study has found a significant decline in annual precipitation and longer dry spells. The area is experiencing more extreme weather events and meteorological droughts, especially in the middle and upper parts of the Shilavati River basin. Purulia has experienced a 65% decline in agricultural output between the years 2001 and 2009. It is also low on the human development indices in the state and faces issues like land degradation, hunger, and economic losses due to drought events. Crop production faces a major challenge as annual average rainfall has drastically fallen from 1617 millimeters to 980 between 1990 to 2018. So the methodology was a simple case control study, which was community based, and the two most drought blocks, Bang, Bundi, and Manbazar 1 from Purulia were identified. It was a pilot study for 30 households, including two groups, migrant versus non-migrant households. To understand migration, a livelihood strategy descriptive analysis was conducted. The result from the socio-demographic scenario was out of the whole population surveyed, 17% were migrants, and males were the largest section of migrants, forming 86.21% as compared to only 46% in non-migrants. The age profile again is like 15 to 64 is the range which sees most migration, 96.55%. Average years of education for migrants is only 7, while that of non-migrants is 10 years. Average land holding sizes is also drastically very small in the group of migrant population. In terms of occupation, we see 25% of non-migrants were involved in agriculture, which is quite small than that of the migrant population, which is 44.8%. And non-agricultural works also involves more of the migrants, 55.2%. After migration, non-agricultural wage work status includes those of construction workers, 47%, which is the largest section, and the others move into brick kiln work, 38%, and 25% is other works. Average annual income for migrants involves about, in agricultural sector, 52,000 to 75,000 annually, and for non-agricultural wage workers, it is 56,000 to 75,000 INR. Interstate migration is what is seen from the study, where most of them move on to Tamil Nadu, Rajasthan, Karnataka, and Kerala. And intrastate migration involves the people moving to better districts in terms of facilities and resources like Kolkata, Howrah, and Bardhaman. 75% of the migrants have migrated for less than 6 months, and only 25% have migrated for say 6 to 11 months. So the nature of migration is more of a seasonal. Expenditure pattern of the migrants is also like 62% goes on food, Debt repayment is 33%, and we see education is 3%, but health and some other expenses get the minimum. Why do these people migrate? Besides the climate event, besides drought, they have crop failure. The inclination for migration is contingent upon the extent of households landing. Small and marginal landholding households, especially those with a greater proportion of cultivable fallow land, were found to migrate. Lack of job availability is the first and important reason for migration amongst 48.3% of the surveyed population, and 37.9% had existing job not being sufficient to meet their expenses, and the others, about 13.8%, had debts to be repaid. Now, who decides when to migrate or even where to migrate? So the largest share is 75%. The family decides who will migrate and when and to where. And only 25% is decided by the migrants themselves. So migration also has health impacts, and we see that most of them have 50%, that is, have a musculoskeletal problem. 20% have tuberculosis, which might be attributed to lower nutrition, unhygienic living conditions, and typhoid 12.5%, again restricted or limited availability of safe drinking water and clean food. Skin disorders were found in 16.67% of the migrants. Satisfaction level of migrants. We see that around 25% are satisfied with the food availability, 21% with the 2% with the education, and the lifestyle 21%, employment possibility 28% of them are happy, and debt repayment 24% are able to do that. But dissatisfaction level of among the migrants is also related to health condition, which is like 41%. So clearly, the health of the migrant is something that really suffers, and out of which mental health is really a concern. They are mostly anxious, perhaps about the future, about how they can repay, or maybe just the homesickness. So 50% are anxious. So we can say that migration from Purulia district is predominantly seasonal, and it functions as an adaptation strategy for impoverished households to diversify their livelihoods and alleviate the risks associated with climate sensitivity affecting their means of subsistence. However, in the process of migration, the quality of life is often compromised. Physical as well as mental health of the migrants is impacted as a result of migration, and also limited access of healthcare services in the destination areas. And developing strategies and resources to assist communities in preparing for potential displacement due to climate impacts, ensuring that migration is safe, dignified, and voluntary, should be able to help this situation. So, thank you so much for your patience and time.
Thank you. Thank you, Dr. Sajda. I have a few observations on your presentation. Let me express them first, and then I'll open the floor for others to ask questions. So, first of all, I think it's, is it, I don't know to what extent it's the right approach to, connect climate change and drought in the context of Purulia. Purulia and Bankura have been consistently
We didn't.
Purulia and Bankura, to some extent parts of Birbhum, they are historically, it's a drought-prone areas, and this is nothing new about the drought in Bankura and Purulia. And seasonal migrations have been taking place. Maybe the interstate migration is a new thing, but what we cannot say with a statistical strength, because your sample size is very small. You mentioned that you had 15 of course, you mentioned that it's a pilot study. So you had 15 household as non-migrant and 15 as migrant, right? And all the percentages that you have shown are based on those bigger numbers, right?
Right, sir.
So yeah, so that's one has to read a bit carefully when such some strong claims or inferences made based on very small sample size. One thing I found very interesting, which stands out from your findings, is the mental health issues. The anxiety among the migrant workers. Now,
Yes.
this is something we also observe, and this is not related only to the migrant workers. This is also related to the left behind the children and the wives. Many of these migrant workers are married, and then they a substantial time of the year, their children actually they don't see their children, right? And the children also don't get to see the father. So we have done a study a few years before, and we found that the father's migrations significantly affect the psychological health of the left behind children, especially among the interstate migrants, and it affects the boys more than the girls. This is something I think you
Yes, sir. You're
if this
absolutely, yes,
yeah
you're
let me
absolutely right
yeah.
in this observation, sir,
Ah.
because it is really there.
So this is, since this is a pilot study, and I guess that you have a scope to enlarge the canvas of the study when you actually probably take up the now another I don't know what you have mentioned drought for mentioning the districts, Maharashtra and West Bengal. But another district which also to some extent, people say that it's a lot of migrations we see because of the large climatic change is South Chobbish Pargana, South 24 Parganas. So this is one thing, and then okay. Few other, since you probably will have another scope to expand the study, so I would suggest you to look at this health issues, especially the depression, loneliness, not only among the migrants but also the leftover, left behind the families. There
Yes,
is
sir, it is there in
one
part
issue.
of our protocol. We have just not been able to do a full-scale study. So yes, we
Yes.
agree on that,
So
and
you have
it is
included for
there.
the left behind family, right? Yeah.
Yes, sir. Yes, sir.
Second thing, which was mostly actually, since you said that it's also the study that the Suraya presented and you presented, it's a integrated, right?
Yes, sir.
It's
Kind of
is it a part of the larger study? So one
no.
point I wanted to mention that the gentleman asked these questions in the previous Dr. Miko, the access to healthcare. Now we know this. Most of the states are covered by the centrally sponsored healthcare scheme, Ayushman Bharat, that Pradhan Mantri, that health yojana you have, Jan Arogya Yojana that you have. But the problem is that West Bengal is not West Bengal did not join this program. So the portability of your Ayushman Bharat card is a problem when you're like, by now if you do a survey, you'll find that majority of the rural households are covered by the uh, uh, state government sponsored health insurance schemes, Sastha Sati. But since Sastha Sati is something which is which is completely by the government of West Bengal, and it's nowhere actually connected to the larger issue that that the other states are having, which have accepted. Few states have not accepted this, the central government scheme. So that portability is an issue, and you have outside West Bengal, you have only a very limited limited list of impanel hospitals. You can actually use your Swasthya Sathi card. So portability of this insurance card is an issue, and even we have seen, with the exception of Kerala, most of the states, the migrant workers, the interested migrant workers, they had to depend on the private facilities for getting the basic curative health care. So health is a big issue, and for the migrant workers, a very not even 20% of them have life insurance. You know, they are not protected from the accidental coverage. You know, there is a lot of issues for the occupational, taking care of the occupational health hazard. There is no clear law, or if it is there, it is not implemented. The migrant workers are not aware of, and a large part of the migrant workers are the independent workers, so they are not coming under a permanent employer or contractor who can be made liable for any accidents or any occupational related healthcare need. So health is a health is a very significant and overlooked issues for these migrant workers. So since you have a scope to expand this study for a larger study, I would suggest you to, if possible, to include some of the points that I have mentioned. Thank you very much. Now the floor is open for questions.
I think Sir Miriam Orkut has joined, so I think she will be able to make a presentation.
Okay. Yeah. Yes. Okay. So we'll have the questions at the end. Our first presenter has just now joined. So may I invite Dr. Miriam Orkut to make her presentations, and her topic is South African National Research Agenda on Health, Migration and Displacement. It's over to you, Miriam.
Thank you very much, and it's a pleasure to join you today. So my name's Dr. Miriam Orkut, and I work in headquarters WHO with the Health and Migration Programme. And today I was going to share with you about our recent work in South Africa with the National Department of Health and the WHO Country Office, particularly around the development of the first national research agenda on health, migration and displacement. But first of all, I also just wanted to put it a little bit in the global context, because of course at WHO we work within all of the different regions, and we provide technical assistance and support, particularly to countries who are promoting the health of refugees and migrants and promoting inclusion of those within the health system. So I'm going to provide a very brief global context as well. I'm just going to see if I can share my screen. Okay. Can you see my screen at the moment?
Yes, it's visible.
Yeah.
Okay, great. So I'm just going to move to the first slide. So as you well know, and I know we're focusing today on specific national context, but just to give briefly a global picture, we in 2022 we released our first world report on migration health at WHO, and this highlighted a few things. One is the number of people. So 1 in 8 of people globally are either migrants or displaced from their homes. This includes internal migration as well. Of course, we know that migration and displacement are key determinants of health and well-being themselves, and that often some of the mobile populations, particularly those who are in most precarious or vulnerable situations, may experience poorer health outcomes. What we also know is that migrants and refugees contribute substantially towards both development as well as towards economies. And of course, without inclusion of refugees and migrants within universal health coverage, we will not achieve some of the big global health or policy objectives, such as the Sustainable Development Goals. So really, when I'm going to be sharing with you the information at the South Africa level, it becomes within this bigger, broader context. And one of the broader contexts for us at WHO is the fact that all of our work is very much situated within the Global Action Plan on promoting the health of refugees and migrants. And this I've just put up on the screen here to show you the main priorities of the Global Action Plan, which you can see there on the right. And this provides not only a framework for global action to promote the health of refugees and migrants and work at country level with our ministries of health, but it also, over the last year, we've developed the first monitoring framework. So a survey which actually allows us to understand the progress that countries have made in each of those 6 areas of the Global Action Plan. And what we found, I'm just going to share very briefly some of the very, very top level findings. Of course, there's much more detail, but we've had 111 countries across the world who designated a focal point to respond to the survey. We had good representation across all regions. Of course, there's findings within each of those sections of the survey, but just one key point to pull out here for the conference today is that 62 out of the 93 countries that completed the survey did indicate that refugees and migrants were included in at least one of their national health policy or legislation strategies or plans. Now, of course, what that means is that, yes, there has been and is progress in terms of inclusion, but now what we know very well is that in terms of implementation and how that translates into health service provision and access to healthcare, that there is sometimes gaps, not only at the national level in that translation, but at the subnational level or by particular migrant groups, for example, those who might be of undocumented status or irregular status. Now I'm going to pivot and start to focus on the main topic of today, which is around South Africa. So back in March, we, over the last year and a half, actually, we've been collaborating with South Africa, with the National Department of Health, in order to support around inclusion of refugees and migrants within the health system and health services. And one of the first things that we did was to apply one of our global toolkits, which is a health system review. So looking at all of the health system building blocks within a country, in this case, South Africa, to understand what are the opportunities for strengthening the health service system and its essential public health services to include refugees and migrants, but also to strengthen it for host communities. And how do we support the development of more evidence-based health interventions, as well as, of course, longer term, what are the recommendations for moving forward across intersectorally to improve and promote the health of refugees and migrants within the national context. So back in March, we had a week-long field visit and consultations and conference that we held with our colleagues in the Department of Health. We had some stakeholder consultations and field visits, and we did this, and we also did our national research agenda setting in that same time period. And I'll share more about the research agenda setting very shortly. The reason I'm sharing about the health system review is because, of course, whenever we're talking about research and evidence, it exists very much within the broader policy space. And when we talk about strengthening evidence, from our perspective at WHO, is very much about what do we need in terms of to move forward on the policy and practice side to improve and promote the health of refugees and migrants. What evidence do we need? What is lacking? From the health system review, some of the main findings that came up in South Africa were that we still don't understand fully we don't have the data around migrant populations, especially those undocumented. Sometimes the use of health information is limited in terms of particularly trends around utilization of health services. And of course, in South Africa, the sort of universalistic approach is commendable, but there's more information that's needed on how migrant populations and refugee populations might be included within the National Health Insurance Scheme. And then there were some very specific things around language barriers, cultural competence, and of course, things around the need for further operational research. So this came up in the health system review and the field visits. And this will be worked into a work plan with the National Department of Health, and we continue to provide technical assistance from WHO, also with our country office in South Africa and our regional office. But now pivoting towards the evidence gaps. So back in 2023, October 2023, we published at WHO the first WHO Global Research Agenda on Health, Migration and Displacement. This was a result of a 2-year process with over 180 stakeholders from across all regions, working from between policy, practice and academia to determine via consensus, using a participatory approach. We did adapted Delphi methodology to determine what are the priorities at the global level for evidence needed for policy and practice. But what this also did, we actually provided within the research agenda a toolkit and implementation guide that was for other countries or regional level to develop their own context-specific national research agendas on health and migration displacement, because we're very much aware that at the national level, it's very context dependent. There's a lot of different migration contexts depending on which national or sub-national level you're working in. So really what the Global Research Agenda then allowed us to do after its publication in 2023, we've also developed a regional research agenda, and we're working with other regions. It's allowed us to then contextualize this research agenda with the broader frame of the topics that came up in the Global Research Agenda into more deep dives and specificity at the national level. And this is what I'm just going to share with you from the South Africa perspective. So the National Research Agenda on Health, Migration, Displacement in South Africa is actually, it shows quite a lot of leadership from the Department of Health, because it's the first country globally to develop their own National Research Agenda on this topic. Of course, there are now other countries also working on theirs, but it provides a model for other countries, not only within the region, but also globally. And it demonstrates also how global frameworks can be translated into national action. But more importantly, what it really does, because of course when we produce a prioritization and a research agenda, what the real intention is for those gaps to then be addressed. So what it really provides is then an opportunity for stakeholders within South Africa, with the lead of the National Department of Health, to develop a research action plan at the national level. How are these evidence gaps going to be addressed? And that includes actionable things such as not just which actors may address those gaps, but also funding opportunities and implementation opportunities, how to translate this evidence, if it comes forward, into policy and action. So the research agenda really aimed to identify what are those operational research gaps for policy and practice. And we framed it within the context of the triple billion, or promote, provide, protect of the WHO, which includes the topics of how to best include refugees and migrants within universal health coverage, how to ensure health emergency preparedness and response, which is inclusive of refugees and migrants, and how to promote healthier populations, including migrants, those displaced, and refugees. And of course, then to identify these strategies for implementation, which I mentioned. So the methodology was using our existing toolkit, which was developed in collaboration with our WHO Science Division. And this has 6 main steps. So again, it's all in collaboration with our country level colleagues. So it goes all the way, went from over about 6 to 8 months. We went from the sort of planning and framing of how to do this at the national level. We did a comprehensive stakeholder mapping across those working in migration, displacement and health at the national level in policy, practice and academia, which was the step 2. And at the same time, we had a comprehensive literature review of peer-reviewed and grey literature on the topic of migration, displacement, health in South Africa that was conducted by our academic partners. We then collated that, and we had a additional survey, which was sent out to all participants, where we had additional information to analyse. And we then went into our in-person technical consultation in March, which I'll tell you a little bit more about now, which then led to our priority topics emerging, and then of course ultimately it will be published as a national research agenda for South Africa. Now, of course, this involves a participatory approach and convening of actors, but also, as mentioned, you can see sort of the detailed steps there. It follows this sort of validated methodological approach, which of course can be adapted at the national level and was as needed. So just very briefly, in terms of the main findings, So from the comprehensive scoping review, there were 293 publications identified within South Africa that included not just, again, the peer-reviewed literature, but also those government and policy reports that were relevant, as well as operational NGO reports. Now, this is important because we know very well that a lot of the evidence that is collated and produced on the topic of health, migration, displacement is not always published in the academic literature. So it's very important to capture the information that also comes forward from policy and practice. There was a peak publication year on the topic of most number published in 2023. And of course, certain thematic areas came forward as having higher amounts of publication around things like AIDS, as well as mental health and COVID-19. We then moved into the stakeholder survey, and we had very good engagement within that survey, where we were able to then further identify through the survey what are some of the gaps that our stakeholders wanted to put forward. And we then collated the information, and we held a full day consultation with over 100 stakeholders at national level, again, across policy, government, practice, academia, where we went through in plenaries and breakout sessions, going through the different research themes that had come forward in the literature review and the survey, and having a dialogue and debate around the priorities. We also had a roadmap session where we said, what the evidence priorities that come forward, how are we going to address these? What are the priorities at the national level? And that resulted in a roadmap, in the production of a roadmap for South Africa to address these evidence gaps. Now, of course, as I mentioned, there was a participatory approach in the process. It was important to us to invite those who are working within the civil society space in South Africa, and also who are part of the migrant and refugee community. So it was quite a good opportunity, even just that day-long consultation, to bring forward dialogue across these stakeholder groups at the national level. What did we find in terms of the main research priorities that came forward from South Africa's perspective? So first of all, under the core theme 1 of universal health coverage, things around evidence on how to best integrate migrants into the National Health Insurance Scheme, into universal health coverage came forward as a top priority. Some evidence needed around what are the main barriers that are there at both primary, secondary, and tertiary level for undocumented migrants to access healthcare. Topics around cost effectiveness, around mental health services. Then also big themes around data systems and monitoring. So how to best develop migration sensitive indicators for integration into health information systems, as well as topics around maternal and child health. This was all under the UHC topic. Under the core theme 2 of health emergencies, some of the key research priorities that came up were around disease surveillance and control. So lessons learned from COVID-19 and how to translate this into future preparedness strategies that are inclusive of refugees and migrants. And then, of course, a key topic around climate change and health. So there was a big research gap around the health impacts at national level of climate-induced displacement, but also around aspects around health system preparedness in the context of climate change. And again, on health emergencies, how to adjust and include refugees and migrants within health information systems during pandemics or emergencies. Finally, the final core theme around social determinants of health. So the core priority areas that came forward were around housing and community settings and the impact on migrant health vulnerabilities. What are some of the occupational health risks? Not only particularly sort of thinking about long-term health impacts of hazardous work conditions, but also specific contexts like within the mining sector and low-wage migrant workers. So what are the immediate priorities from this? Of course, one thing is there's going to be the publication of the National Research Agenda on Health, Migration, Displacement for South Africa, which will allow a consolidated, comprehensive approach at the national level to moving forward with these priorities. But also from the WHO side, we continue to work very closely with the National Department of Health and with key academic stakeholders at the national level to try to address some of those priority areas, one of which being how to best include refugees and migrants within the National Health Insurance and within financing models within South Africa, and another being around the health workforce training for cultural competence. Now, we have some existing tools. We have a existing toolkit at WHO which allows us to conduct those trainings, and this is something we can move forward with immediately to ensure that there's more migrant inclusive service delivery. And of course, some specific areas and specific populations within the migrant refugee populations in South Africa to focus on as well. So, of course, one of our sort of areas of focus at WHO is, of course, around strengthening, not only supporting strengthening of evidence base and evidence-informed policy making, but also to provide knowledge exchange opportunities. And one of the things that is very much important about, within the South Africa context is the fact that they've conducted this health system review plus the national research agenda setting at the same time. And there's an opportunity also to look at what the priorities are that have come forward, and then have a sharing, have policy roundtables, have sharing about what is best practice within some of these priority areas from other country perspectives, for example, health financing. So one of the things that we have been doing, because this is one of our priority areas at the global level, is we also have a global evidence review, so comprehensive literature and knowledge collation around the topic of health financing and how to best include refugees and migrants, which includes some country case studies, but that can help to provide a framework to support further work and translation of the global picture into the national level around the topic of health financing. What do we know very well is that, of course, at the global level, we did this landscape review. We did this funding review around the 9 major global health funders, research funders, and where the research funding streams are directed, looking at the context and the themes that came up in the global research agenda. And what we found, which was quite interesting, is not only are the vast majority of those big grants going to actually just a very small number of countries and regions. So we found that 97% goes just to 2 WHO regions, region of the Americas, region of Europe. But also that one of the core topics where we know there's big evidence gaps, as you can see from the research agendas, which is around generating evidence on inclusive universal health coverage and primary healthcare, is actually the topic which had the least funding directed to it. So there's obviously a gap here between what is coming up as research priorities for policy and practice and where the funding is actually going. And of course, there's always something around the sustainability and the length of funding, because, as we know very well, collating evidence and research and strengthening that is one thing, which is very important. But actually, if you don't have the policy engagement and implementation and translation into policy and practice, which is often the next step after, the findings, that it will not be, the impact won't be as visible. So what we really called for in the global research agenda, and this is where our national research agendas also slot in, is around not only committing to strengthening high quality research on the topic of health migration displacement, but also to building research capacity and building translation of research into policy. And this is where what we have very much highlighted is the evidence and policy for policy making and for action needs to be inclusive, particularly on this topic, if not on many other topics as well, needs to be very much inclusive of those populations who are migrants and refugees themselves, but also inclusive of policymakers and inclusive of operational actors throughout the process, so that it's not just a conducting of a research and evidence on a topic and then trying to disseminate the information, but actually having your policy voice, your policy perspective, and your operational or NGO voice as part of that process of identifying the research question, conducting the research, and of course then they have the ownership and engagement in terms of translating those findings into policy and practice at the end. And of course, what the final thing, just to go back to, which I mentioned at the beginning, is that again, we know very well that we can't achieve any of the universal health coverage, achieve healthier populations for all, or prepare effectively for health emergencies if we don't include those populations who are often most marginalized or vulnerable within our communities, many of whom may be those who are migrants, refugees, or displaced populations. If we don't understand the evidence, if we don't count those populations, if we don't have the data, then there's no way that we'll be able to understand fully their health needs or the health system or service access. And of course, then it leads to a gap in terms of translating that into policy action often. On the other hand, we also know there are a lot of good practices and a lot of examples at country level where there is inclusion or there are mechanisms for which are working. And that is also one of our roles, is to look at, what also is working and how do we make sure that other countries can also understand from that context specific example, can also learn from those, and there's knowledge sharing as well. So I'm going to stop there. We work, obviously, as I mentioned, across all countries and regions. One of the things that we do also have on our web page is our Global Evidence Review series, which covers a number of different key priority topics at the global level. So we have NCDs. We also have our, as mentioned, one coming out soon on health financing. We'll also have another on climate change, which will be coming forward as well. But I'm going to stop there and looking forward to any discussion further. Thank you.
Thank you very much, Dr. Miriam. It looks like you have a very ambitious plan for South Africa. It really sounds great. I'm very clear. I have a quick questions, and that's also relevant in our Indian context. When the COVID-19 broke out, and we had this big crisis with regard to the migrant workers who are scattered in different parts of the country, and the state governments actually even the central government, we never had a clue about the volume of migrant workers who have migrated from one state to another. So the evidence base is very weak even still now. I don't know about South Africa, but in Indian context, the last migration survey, all India basis migration survey that we had was in 2009 and 10. Of late, the India's National Sample Survey Organization, they started collecting some information about the migrant workers, the households where they have migrant workers, but it's limited to the work, the employment aspect of the migrant workers, and nothing related to the other, well-being such as health and education and other things. So when you are talking about the baseline assessment and knowledge, what is that step 3? Are you going to build a information base by conducting a large-scale household surveys or large-scale surveys? Because displacement, if you want to include the refugees, then it cannot be even a household survey, because so what is actually the step 3 that you are referring to? What you are going to build the information base for, where you can as a baseline for starting your intervention. That was my question.
Thank you. Thanks so much. I think I understood the question. So, but do follow on if I didn't. So in terms of just briefly, actually, because I was hearing in another conference, actually just this morning in South Africa, it is interesting because they do have inclusion of, because when we talk about internal migration, of course, which is, in many countries, it is actually the most common type of migration. So when we talk about internal migration, it varies a lot at country level in terms of the collection of that data. But in South Africa, there is actually inclusion of interprovincial migration, as well as, a collation of why people are leaving their previous place of residence internally within their census, which I think is, very interesting. So they look at kind of they were sharing the census statistics. South Africa was sharing the census from 2022, and they have the information around which provinces have the highest percentage of the population who are born outside of the province, which I think is Gauteng in South Africa. But also they do understand, the reasons for for that movement. So this can range, of course, depending on whether it's a forced movement or voluntary or for labor, can vary from, because of natural disaster or drought through to because of political instability, etc. But of course, there will always be a high proportion where it's looking for paid work or a new job opportunity. So I know in South Africa they collate this data. Now, of course, that's one thing, which is the census. But then I think where we come to more of a challenge, and actually the interesting point I just wanted to note that one of my colleagues at WHO actually leads on the data stream. So my area is research and evidence, but he's leading on the monitoring and data side. So I may not be able to answer all questions, but in terms of the data challenge that we have, is the fact that in many, many countries, even within the existing data collected, they don't actually disaggregate by migrant status. So we don't actually have that information. And so one of the things that we actually encourage very much is not necessarily even adding additional indicators, because we acknowledge that this is probably often a big challenge and a big monetary cost, but actually inclusion of that disaggregation from the existing data which is collected. Now here, when you talk about the household surveys, I just want to highlight one thing, which is that WHO also does have does support something the World Health Survey Plus, which is household and population surveys. And a couple of years ago, it was in Kerala that we actually worked with them to integrate a component around migration. So there is also that opportunity to work with existing surveys and integrate that migration component, which can be very, very important. But still acknowledging there's a gap, a big gap. And if we don't collect and collate and disaggregate the right data, then it's often impossible to have the right information. So I think that was the main point I wanted to mention, but I'm not sure if that answered the question.
So now the floor is open for others to ask questions. So you can directly ask the questions to the presenter, or if you can type the questions, I can read it out. Any question? Yeah, Dr. Miriam, can you read the questions here in the chat box?
You see one question.
Refugee or migrant names already result of. Okay.
So it's
you
about
have already answered, right?
Sorry.
Okay.
So I think it covers it. It points to something very important, which is that, of course, when we talk about the migration and displacement and health, or migrants and refugees, it's a very diverse in terms of population. Okay, so I think there, when we talk about displacement or someone who then as an asylum seeker or is applying for refugee status, it is a forced movement. So that is inherently implying that there's either, a crisis or a conflict or a persecution that is causing that person to move. Might be across borders, or it might be internally, of course, internal displacement. So I think that's something just really important to acknowledge. And that globally is much lower numbers, those who are refugees or forcibly displaced, than those who are migrants who are voluntarily moving. And that might be international migrants who move across borders, or it might be internal migrants who move. And as I said, there's many reasons people will move, but often that can also include labor migration. So people who are moving for work reasons. So that wouldn't be because of a crisis, right? That would be a natural movement that is occurring often rural to urban. Now, of course, when we think about the health needs of those populations, it's very, very different when we're considering those who are working as a low-wage migrant worker, those who are internally moving, those who are moving across borders as international migrants. So it's one thing to be very aware. So I think the question is actually talking about, if you think about crisis, it's talking about forced displacement and refugee health. And yes, of course, in this instance, it's very important to consider the health needs and the reasons for displacement from all of the steps of that movement. So that would include the conflict environment where they are coming from originally. They may have often been displaced multiple times within their country of origin, and that has different health implications, of course. But then, of course, when moving across, for example, if they move across a border or they apply in a country of destination for refugee status, that of course that consideration of what their health needs are within those countries is needed, but also, yes, of course, to understand why they moved in the first place. And if we look at root cause analysis, yes, we of course would like to have a world where we do not have the conflicts which cause people to be forced to move from their homes. So yeah, I think some of those sort of policy and international development sides are just as important for this topic to understand and acknowledge as it is, the health side, because health and migration is not just about health services, it's also about the broader collaboration between all of the aspects of response. Thanks.
Yeah, so I just wanted to add one point here. So in India, I don't know about South Africa, but in India, one part of the forced displacement is because of the development induced displacement. So if there's a large public project, so there's a construction of dam. So all the villages, or there's a land is taken over by the government to give to the private companies to build a large factory, building airport. So there are a lot of case studies in Indian context where development displacement took place not because of any conflict or any collapse of the policy, but because of development, quote unquote. So I don't know whether you also have similar situations in South Africa where some developmental projects also made a large number of people displaced from their actually original habitats.
Yes, absolutely. And of course, then also I think that important, it may not be linked to those examples, I don't know them specifically, but with climate change and with aspects around, scarcity of water, etc., I think there will be increasingly seen these sorts of movements which have to be acknowledged and, of course, hopefully planned and prepared for in terms of health service provision and health systems that are ready to respond to that as well.
So if there is no more questions, so I want to thank both the presenters, Dr. Miriam and Dr. Sasta, for very informative and wonderful presentations. I also thank the people who attended the session. So thank you very much. Now I can request the coordinator of this event to move to the next program. Thank you very much.
Hi, good day to everybody, and it's a pleasure to listening to this conversation. And Dr. Mukherjee, thank you for coordinating such an important session. And let us now hand over to conclude the session by Dr. Paramita Bhattacharya from the JBI CPHR India. And we like to, before I hand it over, it's really a pleasure to listen to this rich conversation. I think you all probably agree that we learned a lot today for this conversation. So over to you, Dr. Bhattacharya.
Thank you, sir. It was really a pleasure to listen to such insightful talks. Now, on behalf of the organizing team at JBI CPHR India, JBI Ekurhuleni, South Africa, the Temperley University, and University of Pretoria, I would like to deliver the vote of thanks on today's important and insightful symposium on managing health of vulnerable populations with a focus on migration and displacement. First and foremost, I extend our sincere gratitude to our keynote speakers and panelists, Dr. Nicole Valentine, Dr. Mariam Orkut, Dr. Miko Perkio, Ms. Soraya Roy, and Dr. Sajda Khatun for sharing their rich insights, experiences, and evidence-informed perspectives on addressing the pressing health challenges faced by the displaced communities across various regions. Your contributions have truly enriched this discourse. To our session chairs, Dr. Subrata Mukherjee and Dr. Miko Perkio, thank you for your thoughtful moderation and for guiding the discussions with such clarity and engagement. I would also like to extend special thanks to Professor Joe Jordan, Professor Ute Pyuch, Professor Jayati Kusari Basu, Dr. Gokin Depo, and Dr. Devashish Basu for setting the stage and strengthening the JBI network's commitment to global collaboration in public health. We are also grateful to our collaborators, the World Health Organization, the South African Public Health and Prevention Medicine Association for their enduring support and partnership. To all our participants, academics, practitioners, policymakers, researchers, and students, thank you for being part of this important conversation. Your engagement was truly what brought these sessions to life. And lastly, a heartfelt thank you to all the organizing teams in India, South Africa, and Finland, whose seamless coordination made this global hybrid gathering possible. So let us continue working collectively to ensure health equity for all, especially for those most at risk and on the move. Thank you, and we look forward to meeting again for future collaborations. Thank you all. We would now request all to switch on the cameras so that we can take some photographs. Thank you. So I think photographs must have been taken now. So thank you all for your participation. Thank you so much.